Welcome, everyone. My name is Dr. Bruce Struminger, and I'm an associate professor at the University of New Mexico at the School of Medicine, and just want to welcome everyone to our second round of COVID-19 One Health updates, this one for AFROHUN. And I'm going to be doing a little bit of housekeeping before we formally begin. Right now, I'm going to share my screen. This is our agenda, and we'll come back to that in a moment. First, I wanted to let everyone know des services d'interprétation sont disponibles. Vous avez besoin d'une nouvelle version de Zoom pour cela fonctionne. Choisissez de couper la partie anglaise de la session de écouter les deux. Le français sera plus fort. So please use the chat for communicating with Echo IT to troubleshoot any problems with Zoom. And we ask you to use the Q&A feature for questions related to the presentations. This session is being recorded and your attendance is consent to be recorded, so thank you for that. Presentation slides and a link to the recording will be shared by email with everyone who registered after the session, and will also be made available on the ECHO and UC Davis websites. There's a link to the COVID-19 One Health Update social media guide that we'll be putting in the chat. So please take a look at that. It's a great resource for helping you think about social media and promoting this One Health education effort related to COVID-19. And there will be continuing professional development credits. So near the end of the session, we'll put a link in the chat so that you can get University of New Mexico, CME, or CPD. Please claim your CPD and provide us with feedback. That's how we can improve what we're doing and hear what new topics you want to learn about in the future. So with that, I'm going to pass the talking stick to Dr. Wautrina Smith, or actually to Jonna Mazet, to welcome us formally.
Hello, and thank you for joining us. We're really pleased to be having this second installment of our One Health Workforce Next Generation platform ECHO for COVID-19. And for those of you who joined us for the first ECHO, we were very much downloading lots of information. This time we'd like to move into a more richly our community of practice with more questions, and we're going to have a focus on community surveillance. Of course, in many of our countries where we're living and representing, there have been a lot of activities that include contact tracing to certain extents, but that really relies on having the ability to do great testing. So I know in some of your countries, there'll be a good opportunity to have testing ready and available. In some others, like my own, we might have missed some of that opportunity early because this disease has so much mild cases and even asymptomatic cases, so it makes it very difficult. So we're interested in your challenges and supporting the academic community to be a great source of information on all topics related to COVID-19 and emerging infectious diseases. But we're thrilled today to have some wonderful guests globally, especially talking about community surveillance from a digital perspective, and then from the region, speaking about what's happening on the ground. So with that, I would love to hand over to our AFROHUN colleagues, though we may have some issues with their having signed in. Yes, there we go. Dr. Irene Nagaga, could you please welcome us on behalf of AFROHUN?
Oh, I'm here. I think.
There you are. Okay.
Yes.
Okay.
You can't recognize me because I'm an old man.
No, I didn't want to. We didn't see you there. Okay, fabulous.
Yes,
Professor Bazeyo.
I have been there watching.
Okay, fantastic. Please welcome us.
So, Jonna, nice to hear from you, and I welcome all the members that have come on for this discussion. I think it is great that we continue as professionals to discuss, and then we find ways of mitigating this challenge that we have. I'll just briefly talk about Uganda. Uganda, we have been slightly fortunate that on the request of the president, everybody that passed through the airport from a certain date to the time we closed, people reported back. It was not very difficult. Of course, there were very few people who do not want to come back, so they were being quarantined. And then the community, as we are talking about the communities in Uganda are used to these epidemics. So it was very easy for the communities to point out to those people who have passed through the airports, and they were able to report them, and then they were brought in, and then they have been screened one by one. And so far we have 53 cases that have been positive. And I must say that none of them is in any critical condition that requires a lot of attention. They are in hospital. And then we have more than 2,000 people that are quarantined right now that were either they passed through the airport or they through other borders or had contacts with these people that have actually tested positive. But coming back to our topic, when we talk about community surveillance, I think one of the things that I must let my colleagues know, how did we manage Ebola in DRC and Uganda? The most important thing was to put the community at the center of the management, so that the community were equipped with information, with the basic information, the diagnosis, and how to recognize this problem. So over the last week, we've been discussing how do we now do community surveillance in this country, given that we cannot actually test everybody because of the costs. So we have designed, and starting with the next week, we will be having training courses for the trainers, TOTs, so that these people will now go to the communities in the different districts, train the communities, the healthcare workers, the village health teams. We have the village health teams, we have the the district health teams, so that we train them, and then they will be able to sensitize the people, so that one, it removes stigma. If somebody is being examined, what we have found that when somebody hears that a neighbor is being examined, now they turn around and shun away from that neighbor. It becomes a criminal case. So and so was examined in the neighborhood. So we want to remove that stigma using the communities, and because of that, the training starts next week. The second thing is that using the communities, we want to be able to make early diagnosis, alert the healthcare workers to come and do the tests. But one thing that I must say, and I think it is interesting for everybody on this, is that Makerere University, the team that developed the Ebola testing kit, have embarked on this, and they have already done their tests of using their own rapid tests, which takes not more than 30 minutes to make a diagnosis. we are getting the reagents in this weekend so that we develop it. It is already piloted on those that have already been tested positive and those who are negative. And we have actually find that it works. It will be the first one, the first test that will be on the market for rapid testing. And we hope that we are going to start using it in the communities that are surrounding the borders of Uganda. Those people, because we have a porous border, people keep coming in and going out. And then we hope that with time we should be able to roll it over and use it in the communities, in the community surveillance. So just to wrap up, we need the multi-sector, multicultural, multidisciplinary groups in the communities to accept that, yes, this is a problem. How do we identify it? How do we manage it? The communities must accept that this is a problem within the community. Then there are things in the surveillance. We are looking at the things that we have told people to do: hand washing, social distancing, and of course we can't talk about sanitizing the whole community, but hand washing with soap is something that has been now embraced. Social distancing is still a problem because people still don't want to be away from their neighbors. But we believe that with the sensitization through these trainings and sessions, we will make a breakthrough. So my appeal to my colleagues and all of you on this discussion is that, yes, the disease has come, but as One Health practitioners, we can help our people, our communities, our farmers, our veterinarians to spread the message, and then we will be able to defeat it once we get these cases and manage them. And of course, the last thing I must say that we are planning to do, and we encourage others, is that isolating patients in the communities or anybody tested positive, we want to move it away from hospitals or health centers or health units, so that we will establish isolation centers in the communities, in the different districts, so that those people are able to put these people in places that they are alone and are managed there. In that way, we are going to use what we call the epi tent, and I think Irene will give you a link later on to look at what the epi tent is, which was sponsored by USAID through our project of RUN. The epi tent has been tested in Uganda, tested in West Africa, and we know that it helps in isolation, reducing contamination and the cross-transmission of diseases from people from the patients to the healthcare workers. So that's why we are, and we welcome all the ideas, but most important, how we shall defeat this disease is involving the communities in the management of the cases and the diseases, and the disease and the prevention. Thank you very much, Jonna, and the team.
Thank you. Back over to Valtrina.
Okay, so let's go ahead and kick off our topic for the day. It's wonderful to see everyone getting logged in and to be together again. As you heard before, community surveillance is the focus. Of course, we can talk about other things as you would like during the question and answer session. But right now, I'm going to hand the baton to Dr. Brian Bird to give us a quick introduction and any late breakers or updates you'd like to share as we get going. And then we'll have Dr. Madoff.
I have to unmute myself. So hi, friends and colleagues. It's great to be talking with you again here on the ECHO chat for One Health Workforce Next Generation. Thank you to the organizers and Dr. Bazeyo and Dr. Mazet for this opportunity to talk with you. And I'm going to talk a little bit about just the introduction of community surveillance and how we go from talking with communities, as I am here with a group of people in Tanzania with our close colleagues there, to these global pandemics and why that's important. And I cannot advance my slides. Weird. Okay. What we have to keep in mind, though, this is a principles based in One Health. We're interested in zoonotic diseases and how those are spread from animals to people. And community-based surveillance is just one part of that. And One Health approaches to thinking about how these diseases move in our environment is critical. We cannot forget that these diseases start in animals and then spread through our communities, through us, through human-to-human transmission. So from a global perspective, yesterday we crossed 1.5 million cases globally. That's 184 countries. So it truly is a global pandemic now. Across the African continent, there's a little over 10,000 cases, according to Africa CDC. And I'd like to point out on the picture here, Africa CDC now has a very nice dashboard that you can link to and keep up to date on the situation across the continent. And the web link is down in the lower right-hand corner there. So 52 countries, so most of the countries on the continent now have cases, so you're not alone. We're all in this together, whether in the United States, Europe, or across Africa or Asia. In the last 2 weeks since we last spoke, I spoke quite a bit about animals and which animals we think might be able to become sick or infected by the SARS-2 coronavirus and develop COVID disease. And we know a bit more these weeks than we did before. Again, we're recommending strongly that people that are sick with COVID disease and their contacts should avoid contact with animals. We know now that certainly dogs and cats and a few other species like ferrets and some other animals can be infected by the virus. We even have reports in our country here in the United States, in some of our zoos, that large cats, so cats that are big predator animals, so like tigers and lions, can be infected and can develop mild disease. So from a conservation standpoint, we're thinking about One Health, animals in the environment, and how we interact with them. Let's limit our contact with these animals during this time of the pandemic. Fortunately for us, from a food production standpoint, there's been a few experimental studies reported since we last spoke, and it does seem that chickens and other birds and pigs seem to be resistant to infection. So that's good news for us. And here's just an example or a schematic that I pulled. The web link is to the right there of the phases of responses to disease outbreaks. You go through steps of disease control, these community-based interventions, and then eventually we get to vaccines and drugs for new emerging diseases. But what I want to point out is that community-based surveillance can be impactful at all of these phases. It's not just in the community. The community-based surveillance helps us find cases early, do contact tracing, really engage with the communities. We know that is critical in fighting against these types of diseases. And then knowing if someone's sick at home, what should they do, right? You're going to hear from other speakers later about some very interesting and fascinating ways we can use technology to improve those surveillance efforts. But let's not forget that really starts with a conversation. Outbreaks begin in a community and they end in a community, and we can't forget that. And here's just some links in my slides from that's been updated since last week, and you'll have those there as a resource. And with that, I'll turn it back to Dr. Smith to carry on with the conversation. Thank you.
Sure. Thank you so much, Dr. Bird. So a quick reminder for everybody, I'm glad that you're starting to use the chat box. And on this session, we actually have two different ways to type in your ideas. The main chat box, which is what people have been using now, is a great place to say hello or to really coordinate and share ideas. If you have a question you would like to specifically ask for the speakers and the panelists today, there's a different tool you can use on Zoom. So when you go to your Zoom toolbar at the bottom of your screen, you have a Q&A tool. That's something that's not always available to us in Zoom, but it is in this webinar format. So feel free to use the Q&A Zoom tool on the bottom of your Zoom toolbar to be able to ask questions that you would like to go to the panelists as part of our discussion today. And then the chat box is still a great place to be able to say hello and share other comments or experiences. So with that, I'd like to go over to our next speaker. Dr. Larry Madoff is here with us from ProMED, and I'll go ahead and have him share his screen and share some of his ideas with us this morning. Thank you for being here.
Hi, can you hear me okay now?
Yep, we hear you.
Good morning, everybody, and thank you very much for having me today. Bienvenue aux francophones, mais je vais parler en anglais. Excusez-moi. I wanted to introduce myself. I'm the editor of ProMED, the Program for Monitoring Emerging Diseases, which is a program of the International Society for Infectious Diseases. I also work here in Boston, Massachusetts as medical director at the Massachusetts Department of Public Health, where we have been pretty swamped with COVID, as I know many of you have been. I wanted to walk you through just a little bit to introduce you to ProMED, which is, I think, a unique kind of disease surveillance. Our approach is global, but the approaches that we use can be applied at any level, from the national to the regional to the local. And that is to use events and firsthand or informal reports to monitor emerging disease surveillance. ProMED was founded over 25 years ago by these individuals, Steve Morse, Jack Woodall, and Barbara Hatch Rosenberg, who recognized the importance of emerging diseases and also the evolution of the internet, which was becoming an important way to communicate. And they wondered if informal, unofficial sources of information could be shared through the internet as a way of moving faster than outbreaks. ProMED started in 1994. It's a system of moderated email lists, of website and social media. And our intent was then and is now to serve as an early warning system for emerging disease outbreaks with an emphasis on rapid reporting and transparency. Our posts are authenticated, vetted by subject matter experts, but it's not a peer-reviewed journal in the usual sense. And our standard is for a 24-hour turnaround time. We often put out what are called requests for information for unverified reports. ProMED is free, available to all, and we currently have about 85,000 subscribers essentially everywhere in the world. We have and always have had an emphasis on a One Health approach to disease surveillance, have really fully embraced veterinary and environmental health, including diseases in plants and animals as part of our coverage on ProMED. Just very briefly, I want to walk through the distinction between what ProMED does and what traditional public health consists of. And traditional public health is what I do kind of in my day job at the Department of Public Health here. In this system, members of the public interact with providers, and providers recognize diseases or order laboratory tests, which then make their way up to officials, either at the local level or at the national or regional level. And these reports eventually find their way to world bodies like the WHO or the OIE in the case of animal health. This has many advantages. Traditional public health is a very large, robust system in many countries, in many parts of the world. It's sensitive to disease occurrence because it reaches out to providers everywhere. It's accurate, it's validated often by laboratory testing, and it's quantitative. It allows us to count cases. But it has some disadvantages too. The public health system can be slow or even erratic, and sometimes there are reasons that disease events don't get reported. Those broken links can lead to completely missing some cases. And if a disease is unknown or uncharacterized, it may not have a box to check on the case report form or a laboratory test. For example, COVID, when it was first recognized, did not have any such laboratory test or box to check. And of course, traditional public health is expensive and it's limited in resource-limited settings. On the other hand, event-based or informal surveillance systems like ProMED interact directly with all of these different sources of information, including astute healthcare workers, members of the public, the media, which is a very rich source, newspapers, radio, magazines, laboratories themselves, local health officials, and health officials at all levels. And you'll notice that the arrows point in both directions because both these information sources can also tell us about things that are happening. Many of our sources are our readers who send us information. And informal surveillance has other advantages. It's fast, it's transparent, it can include any type of event, and it's relatively inexpensive. So you can see that those advantages complement the traditional public health system. On the other hand, we recognize that there are disadvantages, including a potential for inaccuracy or sensationalism. And these systems are not terribly quantitative. They recognize events, but not case numbers or fatality rates. Other names for these sources include informal or non-governmental, unstructured data, rumor reporting, or open source. And the WHO now has a system called epidemic intelligence from open sources, of which ProMED is a part. So ProMED is designed to be an early warning system for disease outbreaks. And in the case of COVID-19, ProMED posted the very first report publicly on the situation in China. And this was that first report. It was recognized by our deputy editor, Marjorie Pollock, who was in communication with an individual, a Chinese-speaking individual who was monitoring social media in China and alerted to this cluster of 27 cases of pneumonia in Wuhan. And this rang alarm bells with Marjorie, having been involved in the SARS outbreak and the MERS outbreak, other coronaviruses. This report was very reminiscent of those early reports as well. This is our web page. ProMED has gone on to publish over 100 reports following the COVID outbreak. And we hope that you will turn to ProMED as a reliable and fast source of information as the COVID outbreak continues to evolve. I want to mention our regional networks, and we have 2 regional networks, actually 3 regional networks that function on the African continent. One of them is called ProMED EAFR, focusing on Anglophone Africa. And this network has been around for about 10 years now. We also have a Francophone African network, ProMED FRA. The correspondent for that network is based in Burkina Faso. And again, it focuses on disease events that are particular to the Francophone African region. And we also have a Middle East and North African network, ProMED MENA. All of these networks are available for free by themselves or in conjunction with the global ProMED network. ProMED is currently run by about nearly 60 staff all over the world. And we are very proud of the work that all of these people do to produce ProMED and keep that product running out to you. It works like this. We receive information from our readers or from a collaboration with HealthMap, another One Health organization based in Boston, or from official reports, media reports, and others. And these reports flow through a top moderator, an associate editor on duty, who then refers them to an expert subject area moderator. And the subject area moderators then review each report and send it on back to the top moderator along with commentary. Finally, these reports are copy edited and pushed out either through email, through our website, through an app, and through social media. As I mentioned, ProMED has always embraced One Health, and we have a veterinary and plant pathology staff that work with us very closely, and we really recognize the importance of animal health in global health. This is just a photograph of some of the ProMED staff that was assembled at one of our rare in-person meetings. Most of our work is done virtually, but this was an in-person meeting in India about 4 years ago. So I want to thank you, and I will have to leave now, unfortunately, for another call, but I really appreciate your being with us today and appreciate the work of all of you. Thank you.
Thank you so much, Larry, for taking time out of your busy day. We really do appreciate you being here, and we can certainly follow up later on if there are additional follow-up questions.
If there are questions, please send them to me and I can try to respond by email. I apologize for having to run early.
No, no problem. We loved having you with us yesterday as well as today to talk with our global colleagues. Okay, so we have one more presentation that we will share, and then we will have a short question and answer session. Then we'll have a couple of presentations representing some of the country perspectives in Africa, one from Tanzania and one from Sierra Leone, to keep our discussion going. And then the rest of the time we'll use for interactive question and answers with panelists. So please do share your questions in the Q&A tool on Zoom, and we'll try and get to that in a couple of different ways as we go forward. We also have a website which has frequently asked questions from the previous session. So we'll go ahead and post the link for that in the chat box as well going forward. For now, though, I'd like to invite Adam Crawley from Ending Pandemics to go ahead and share his screen and some of his ideas. Thank you for being here today.
Thank you so much for having me. Let's see, just trying to share my screen right now. I am getting a message that screen sharing has failed to start. Please try again later. Let me try again one more time. All right.
Yeah, we can see it.
Okay, and are you getting my presenter view or do I need to swap displays?
You should swap displays if you can do that.
There we go. All right, how's that?
Perfect.
All right. Good morning, everyone. Early morning here, but I suppose it's afternoon or evening for many of our attendees. I hope that you've all been able to remain safe and healthy during this pandemic. Here in California, we're going into our 4th week of sheltering in place, but I think we are finally starting to see that some of our social distancing measures are having an effect. My name is Adam Crawley. I'm an infectious disease epidemiologist working with Ending Pandemics, which is a small nonprofit foundation based in San Francisco, California. And I just want to start out by saying I'm grateful to the One Health Workforce Project and all the stakeholders, to the AFROHUN network, and to Project ECHO for providing me the opportunity to share a little bit about the work that we're doing at Ending Pandemics with all of our collaborators. So our team focuses on providing catalytic funding and technical support to countries and organizations around the world in order to build infectious disease surveillance capacity and improve our ability as a global community to find outbreaks faster. So Ending Pandemics, we take an approach where we partner with governments, universities, NGOs, and technology groups to support the development of One Health surveillance tools that engage the public, train volunteers, and frontline healthcare workers in outbreak surveillance. We're really focused on putting the public into public health. So some of our tools, like Flu Near You in the United States, like the Guardians of Health application in Brazil, and the Dr. Me tool in Thailand, are focused on crowdsourcing symptom reports directly from the general public. We've also worked with groups in Western Europe, in Australia, Canada, and other countries that take a similar approach, conducting syndromic surveillance at the individual level directly from communities in order to track influenza-like illness and the spread of other syndromes. In another example, we work in Sri Lanka and support a tool called MoBuzz, which is a system that's used both by public health inspectors and by the general public to report on suspect cases of dengue, mosquito breeding grounds, and other methods in order to engage in dengue surveillance and control. And one other tool I'd like to highlight before I get a little further into the presentation is a hotline in Cambodia that we've developed with the Ministry of Health and our colleagues at the Instead Innovation Lab in Phnom Penh. The 115 hotline was set up as a nationwide resource free to all Cambodians to access from any phone. They can dial in and receive access to health alerts and health education information, but they can also be routed to a disease surveillance officer at the Ministry of Health to report suspect cases of both human or animal disease in their community. So in recent years, that's scaled up and been used countrywide. They are often receiving 400, 500, 600 calls a day, many receiving access to health information, but often getting 20 to 30 calls a day about suspect clusters of disease. We've now seen that tool scale up during COVID-19 to become the primary tool for reporting and triaging of suspect cases across the entire country. They use that as the point to screen potential COVID-19 cases, to provide health information, referrals to hospitals and testing facilities, and track cases. Rather than 400 to 500 calls a day, they're now seeing 15, 16, 17,000 calls a day, and have staffed up their team at the ministry to handle calls 24/7. I think this is one example of really seeing a community surveillance tool adapt very rapidly to the COVID situation. More specifically, in Africa, we've worked with a group called Medic Mobile, which some of you might be familiar with. They focus on building software for community health workers. We've worked with them in Uganda and Kenya in recent years to pilot community event-based surveillance tools that can be leveraged by community health workers during their engagement, providing primary care, maternal child health services, and other duties, both through the Living Goods Community Health Network and through some of the government community health networks that are operating at the county level in Kenya. But I'd like to take the last few minutes of my presentation to talk specifically about a tool that we've supported in Tanzania for several years. So one of our longtime partners is the SASIDS Foundation for One Health at Sokoine University in Tanzania. Some of you are probably very familiar with this organization. They've developed a tool called AFROHUN, which is an open source One Health event reporting tool. And before I go any further, I really want to acknowledge all of our colleagues at SASIDS who have been just absolutely critical in the development of this tool. Really, I am just here to share and promote their incredible work. That includes Dr. Mark Mamamu, Dr. Ezran Karimuribo, Eric Beda, and Calvin Sandato. So AFROHUN was initially developed starting with what we call an EpiHack event back in December 2015. EpiHacks are a process that Ending Pandemics uses to bring together public health officials, veterinarians, and local software developers and IT specialists to create new tools and systems that specifically address disease surveillance challenges and gaps that have been identified. EpiHacks are collaborative as opposed to competitive events, and all of the products that result from EpiHacks are free and open source so that they can be modified, replicated, and used for a variety of use cases. So we've now held over a dozen EpiHacks over the last 5 years in countries around the world. More specifically, the AFROHUN system has the capability to manage the entire data collection lifecycle, from managing users, loading forms, and collecting data in the field, to viewing that data on a server. The app is designed to collect geo-referenced data both online and offline in locations without internet data, and can be submitted once a user has connection with the internet again. AFROHUN now has hundreds of community health reporters using the tool across the human and animal health sectors, and has processed thousands of reports of unusual health events both in human and animal populations. So one of the unique aspects of AFROHUN is the One Health Knowledge Repository. That's a decision-making system that has expert-authored content and helps to support the prediction of disease conditions based on the signs and symptoms that are reported by community health reporters. Those contents include specific disease case definitions and then percentage weights of clinical signs and symptoms that helps the program to predict the most likely condition being reported based on those weights. And I think this is one point I want to highlight before I conclude, that this is an incredibly powerful design principle that we always try to be mindful of with community surveillance tools. What makes the tool valuable to the user and to the community? I'm sure we've all seen examples where researchers or health authorities gather data from communities, but they never share back the results. And so whether we're engaging communities via email, applications, hotlines, or SMS, the value to the user has to be really clear and convincing for those tools to be effective. So we continue to work with the SASIDS Foundation on expansion of AFROHUN throughout Tanzania. We're developing interoperability with FAO's MII field reporting tool, as well as with some of the laboratory systems in the country. We're aiming to share the tool with neighboring countries. For instance, the SASIDS team has conducted training of trainers on the digitization of various surveillance forms in the Democratic Republic of Congo. And the plan is to deploy AFROHUN at the community level and other potential levels in the DRC. Most recently, we've begun working with our sister organization, the Skoll Foundation, to provide funding to Africa CDC and the SAFIS Foundation to support COVID-19 response efforts. And we expect that elements of the AFI data tool may be replicated and shared with other countries through Africa CDC. So thank you all very much for your time. I'm very happy to answer questions both during this session, but also via email. If you prefer to get in touch via Twitter, please feel free to do that. And of course, our website is endingpandemics.org, and we have a lot more information about our projects there. Thank you so much.
Thanks, Adam. That was great. So what I'd like to do is go ahead and take 1 or 2 questions now, and then be able to go on to the next couple of presentations, and then really spend the rest of the time in some discussion and Q&A. So Dr. Kane, would you like to ask your question using the microphone?
Yes.
Go ahead.
Please, can you hear me?
Yes, we can hear you. Go ahead.
Yes. Morning for
Good
everybody.
morning.
My question is about at this point, as the community surveillance is needed, do you include animal surveillance among community surveillance? Because as I see with Brian's presentation, now there are more animals susceptible like carnivores, cats and dogs, but some species are less sensitive like pigs and poultry. What about ruminants? Is my question.
Wonderful. So perhaps to Dr. Bird, you could give us a little more information on what we know about the animals and should they be included in surveillance.
Great. Yeah, thank you, Dr. Khan, for that question. I think that's an area of active research and things we need to understand more. What we do understand is that it is possible that many different kinds of animals could possibly be infected by the virus, but that doesn't mean that they would get disease or be able to spread the virus further in the environment. So, you know, I think the experimental studies that have been done so far with the chickens and pigs suggest that ungulate animals, and cattle would be in this case, or in that group, you know, with swine, because I've been looking at this actively the last few days. Pigs were resistant, and if you look at the receptor that the virus would use to get into those animals, that receptor between pigs and cows is more closely related to each other than it is to humans. So that suggests that cows would likely be resistant, but to my knowledge, no one's done experimental studies. But I think it is something certainly worth monitoring, and that's where community-based surveillance would be very powerful. It'd be very difficult to do the experimental studies in cattle that would be required to do, but many people across the African continent and here in the United States come into contact with these animals, and if we notice that they are sick with something that looks like respiratory disease, and they've had contact with a sick person, or caretaker or herdsman, then that should be reported up through your chains of information routing through the Ministries of Health and Agriculture. Over.
Thanks so much for getting us started, and we can be circling back to that in the next session if we would like to do that as well. Thank you so much, Dr. Kane, for asking the question with the group. The other question I would like to perhaps have Adam weigh in on, we received a lot of questions in advance of the session, which is great. Adam, perhaps you would like to tell us a little bit more about when contact tracing might be most useful in these sorts of global pandemics.
Sure, happy to talk a little bit about that. I think it's something that every country is grappling right now, and we've quickly realized how difficult contact tracing can be in the absence of testing, especially when you have a disease like COVID-19, where we certainly have seen evidence of pre-symptomatic transmission and very potentially asymptomatic transmission as well. I think what we've seen here in the United States, and I'll just speak a little bit to our context here in California, is quickly reached a point where the resources needed to conduct thorough contact tracing quickly became insufficient based on what we had here at the state and local health departments. I think the hope moving forward is that the significant social distancing measures that we've implemented will help flatten the curve and allow health departments, specifically the state and local health departments here, to catch up to the reported cases as we increase our testing. So I think contact tracing is absolutely critical for a disease like COVID-19. It has to be accompanied by robust testing in many cases, as well as the isolation and quarantine measures. So this can be a very labor-intensive process. Anyone who has ever conducted a measles outbreak investigation can certainly attest to the fact that following up on tens or dozens or hundreds of contacts can be really challenging. And so I think this is where technology can also help support those efforts, but certainly not replace some of the core epidemiologic functions that local epidemiologists play. And so we've seen several kind of approaches emerging where people might be able to be alerted to their proximity to a confirmed case through Bluetooth technology that is exchanged between cell phones. We've also seen mechanisms in which we can develop automated calling systems that will essentially dial contacts that are being monitored for a 14-day period, send them an automated message, allow them to check in and say, I'm feeling well, or yes, I have symptoms, potentially reducing the workload and the burden on local epidemiologists who have to track all of these cases. So I think the more we can find ways to reduce that workload and that burden on the individual health workers, the more effective we can be in contact tracing, because it is an absolutely critical tool, but I think we all recognize it's incredibly resource intensive. So hopefully this is something that the world will continue to recognize, and we'll continue to see more investment and more resources put into public health, because that ground level community-based work of community tracking and contact tracing is absolutely critical to control of a pandemic like this.
Thanks so much, Adam. Very helpful. Okay, so what I'd like to do next is hear from a few of our folks who are on the continent. And so first we'll go to Tanzania. Dr. Masanja, are you able to hear us and to share your screen?
Yes, let me do so.
Karibu.
Thank you. Okay. 1 minute.
So while he's pulling those up, Dr. Masanja is with Ifakara Health Institute in Tanzania, a longtime partner, and I'm really looking forward to hearing what's happening.
Okay, thank you very much, Katrina.
Perfect.
Actually, I saw Brian and I thought I couldn't recognize him because of the beard, and I thought, is this because of the lockdown?
It is.
Okay, so just to give you a very brief summary of the what is happening in Tanzania in terms of the COVID-19. A few reflections from here. A bit of a background. In Tanzania, we received, or the first case was reported on around the 14th of March this year. This was a lady who was coming from Europe. She had traveled to Belgium, Sweden, and then France, and then to Tanzania. Arrived at Kilimanjaro, and actually her host back in Belgium was diagnosed with COVID. So when she arrived in Arusha, she didn't go home. She went straight to a hotel, and she reported to the hospital. And then they started all the routine work of trying to contact all the people that she got into contact, the driver from the airport, but also, everyone who was involved, but also the driver and the family and everyone. So they tried to do the contact tracing in order to make sure that these people were not exposed. Luckily, none of them were exposed. So she was put in isolation and was tested 3 times before she was cleared that she was negative and allowed to go home. But there is a national task force that has been created to respond to COVID, and this is led at a high level by the Prime Minister, and of course with the support of the Ministry of Health. They have various subcommittees on various aspects, such as coordination, because you need to have a coordinated response across many sectors, but also across bilaterals and multilaterals. There is a subcommittee on lab, and to report that one of our colleagues, Grace Mangoka, sits in this lab subcommittee. There is one on surveillance and port and entry ports, another one on logistics, and another one on case management. About 3 weeks ago, the government issued an order to close all the primary schools, higher learning institutions, universities. So, you know, just to reduce exposure in these kind of settings. In the last 10 days or so, they have put a mandatory isolation of about 14 days for everyone who's arriving from places which have been affected by COVID. This is, initially they were put in a hotel and they had paid their own expenses, and people complained because they did not have the budget. But now they're put in one of the university's hostels, which is much cheaper, and they're being followed up. The graph on the picture on the right, this is the status as of yesterday. As you can see, it came at 3 p.m. I couldn't get the latest for today, but until yesterday, there were 25 confirmed new cases. One was identified yesterday. And also this is quite interesting because the one case that was identified yesterday is a case that had no history of travel. And actually today the minister has issued a statement that probably she was talking to the religious leaders and telling them that probably now we have local transmission, and therefore we should be more careful than before. Most of the cases that we have seen before in Zanzibar, Dar es Salaam, Arusha, and one case in Mwanza, all came from, were imported cases. Until now, we have 1 death, 5 have recovered, contacts that are under follow-up around 400. Those who have completed the 14 days are about 376. And the remaining 29 are still under mandatory quarantine, as I mentioned earlier. So today I participated in the surveillance work group. And some of the ideas that came from this group, I actually joined in the middle of the discussion, but thinking is to start putting event-based surveillance through sensitizing pharmacies and drugstores where people come to seek care. There is a lot of self-medication in Tanzania sometimes, and therefore through sensitizing the people, the pharmacists in these places, we might be able to pick some of the cases by a certain definition that they're going to be putting. The ministry has put in toll-free numbers where people can call in and present and ask questions, but also if they're not feeling well, can describe the kind of symptoms they have and be directed to go to facilities for testing. Currently, testing is happening at the central lab, the national laboratory in Dar es Salaam, but of course samples are collected across and brought to Dar es Salaam. We participate also in the lab, as I said, diagnostics committee and team that does that. From what I understand, they usually collect all the samples and test around 2 in the morning. So from 2 to I don't know, maybe early in the morning, to be able to provide and confirm the results, and then for the ministry or for the minister to be able to announce. The current test right now is using a real-time PCR. And what we have done as Ifakara Health Institute is to work with some of our partners, including the Embassy of Switzerland, plus another foundation who are going to support the ministry with an additional 10 real-time PCR machines, but also supplies for around 10,000 tests. But as you know, the supply chains are kind of distressed. So we will only get these machines in the next 4 weeks, plus the supplies. Of course, some are available locally, but of course the bulk will need to be, will come probably in the next 4 weeks or so. But of course, we've been asking about what is the long-term plan, because this is gonna be maybe for another 3 months or so. So The ministry led by the National Lab are putting a plan to see what is the additional support that is required in terms of testing. And from what I'm seeing, there might be some probably community testing coming because remember Jack Ma donated supplies to Africa. So we received about 20,000 RDTs. Of course, the Tanzania Medicine and Drug Administration, TMDA, is kind of validating this before they can be used for testing, basically I think for surveillance. So the other item is community-based surveillance. Of course, the discussion was around case definition. What will be the case definition in this context? Of course, we would like to review their existing standards so that we can have a case definition that is can be used for the community workers that are basically going to be the people who are going to be doing this. Of course, there are a number of tools that people have suggested, but of course they say basically we need to agree that we can customize already existing the electronic infectious disease surveillance and response tools. The discussion again is about supervision of the community health workers. In Tanzania, we have this cadre of community health workers, and actually the facilities that are close by are the ones that will provide the supervision of these CHWs. Discussions about how they can be protected, the safety issues around these community health workers, because they'll be going out there and probably testing people. And most critical is how this information is going to be shared, because you need to share it in a way that it doesn't create any panic, but rather make people behave or act accordingly. The other discussion has been around the death reporting and mortality. And this is something that came up in the CDC, thinking that it is important that we also use some of the existing key stakeholders in the communities, and these are religious leaders, because if there is anything, if there's a death, they will definitely know, because the burial, though they try to minimize, but somehow these people might be involved. You must be aware that there is no total lockdown in Tanzania yet. So, but from what I've been reading in the newspapers and the social media, the minister has said that probably in the next 2-3 days, they might come with announcements, probably on probably more strict measures. But the other stakeholders in the communities, the hamlet, village, and ward leaders, in terms of reporting or mortality in the communities. So this is what I can share for now from Tanzania. Thank you very much.
Thanks so much, Dr. Masanja. Really helpful to hear your overview, and I'm sure we'll come back to you during the question and answer session in just a few minutes. For now, we'd like to go across the continent and go over to Sierra Leone. James, would you like to share your ideas and your presentation on some of the community surveillance aspects that you think would be of interest to the group? Yeah, we can see your screen. Looks good. I can't hear you though.
Yes, good morning everyone, and good afternoon for my African colleagues.
Thank you.
I am sharing the Sierra Leone experience. I'm James Bangura. I'm working with the University of California programs here in Sierra Leone, particularly the Predict and Preempt programs, which are embedded within the Ministry of Health and the Ministry of Agriculture here in Sierra Leone. Specifically, we work within the zoonotic disease unit, strengthening capacity for zoonotic surveillance. So within this response, we are sitting with the surveillance pillar, providing technical services at various responsibilities together with other partners. So I'll share with you this morning with few strategies that have been implemented in the country since we started having cases. Sierra Leone, we had the first case here in March 31st, a traveler that came from France and then has spent his 14th day of mandatory quarantine, which was announced. Then before being discharged, test was done on his discharge and tested positive, which is the first thought is could this be an outlier? On the last day of your 14th day mandatory quarantine and the sample to be collected and tested positive. To date, we have recorded 7 cases, and interestingly, of the 7 cases, 5 have come from travelers coming from countries that have local transmission. And then they have been in quarantine, which is a mandatory activity here for the response. And then on discharge, when we have the first case, the president and the government changed the process that every traveler who completes the 14 days of quarantining should be tested because of the first case that we had. And now the other 6 cases all came as a result of that, and then except for 2. And then since then, one key system that is being implemented within Sierra Leone here in the community-based surveillance is the event-based. Event-based, we're using, the country's using the 117 toll-free system. This was adapted during the 2014 Ebola outbreak, wherein communities, individuals are encouraged to call in and report. This is a 24/7 call center with personnel receiving calls, logging them. It's an electronic system and provides real-time notification to the surveillance groups, and it could be the ambulance system, it could be the various arms of the response. So this is the key approach that the government is using here for community-based surveillance. Within the event-based surveillance system, it encompasses various approaches the country is using. Firstly, with verifying these calls that are coming from 117, and then as well as also following up some of these calls comes in from health facility, and also following those and then doing a comprehensive investigation of those, and as well as calls that are coming from the contact tracers. These contact tracers could they call their supervisors. And then we also have wherein people feel sick because of the ongoing sensitization and the engagement of the community. People walk into the health facility, I'm not feeling well, can you please test me? And then the surveillance officers or case investigators, we call them here, will spend time and then do comprehensive investigation to understand what is happening. Because of that, we also had like a second case that the country recorded is a practicing physician. Then the approach came in, like the hypothesis came, could there be local transmission? Could there be more cases in the various facilities that needs to be reviewed? So the strategy was adapted. Okay, let's have an active case search in the various facilities across the country. So surveillance officers were deployed within 25 major hospitals, especially in Freetown, where we have the outbreak going on now, where we have most of the contacts except for the 2 quarantine homes that are outside Freetown. So we have officers have deployed to review records of cases that have presented with flu-like symptoms in the past 3 weeks prior to the first case that the country recorded. So these are the 2 key approaches that is being used across the country, particularly in the Western area. In the verification of the alerts, I tried to put in a flow, which is very interesting, and this worked so well during the 2014 Ebola outbreak, and it's adapted for this ongoing COVID pandemic. The communities will trigger alert because of the sensitization. Communities are encouraged to call 117. It's a toll-free. You pay nothing, and these alerts are generated by the 117 call center individuals on a daily basis during the 247, during the day from 8 a.m. or 7 a.m. through 5 p.m. these calls are logged and then pushed to the case investigators immediately. Overnight calls are aggregated and then pushed in the morning to case investigators. So case investigators are distributed across Western area is divided into zones, and they divided the city. This is the Freetown, the capital city of Sierra Leone, is divided into various zones, about 10 zones. And these zones are, we have some case investigators in the various zones. These alerts are directed to these officers, and these officers will investigate the alerts, go to the address, and then meet the individual who will have really made the call, and then to review what is the situation. And then within review, there comes in the use of the case definition that has already been adopted. So the country has prepared a lot prior to the introduction of the first case. There had been a lot of technical work that was done already, developing case definitions, adapting contact tracing tools, adapting quarantine tools, adapting various tools that are essential for community surveillance. So these officers will review this individual. With the case individual meets the case definition, the lab team is alerted. And this lab team, when they come in, they collect sample and the individual is isolated immediately for whilst they await the result to come. When it turns out positive, it's taken immediately to the treatment center, which is manned by the military. So the military hospital is being used for managing positive cases. If this individual doesn't meet the case definition, the alert is considered to be false and discarded. And then will not be, we had instances where prank alerts will come. People will just take cases toll free. You pay nothing, and then they'll just call, and then the investigators will go out, and only to find out this was just prank. At the moment, for us in the country, we are at a point where we say we are at moderate to low transmission. And then the focus with the investigation, the community-based surveillance, is comprehensive investigation. We want to know where are these cases coming from. You know, we have 2 cases that are being investigated comprehensively of the 7 confirmed cases to try to identify their exposure. So this takes a lot of time to follow all the interaction, the activities of these individuals, and where they're coming from. And then we also focus, in this comprehensive investigation, focuses on talking to community people. We have these zones that are being distributed. You have contact tracers within those zones. You have quarantine officers within those zones. And then you have the case investigators within those zones. And we have field epidemiologists. The program had trained the field epidemiologists that are assisting all these groups within every zone that they are assigned to carry out comprehensive investigation, talking to people, talking to pharmacy facilities that are there, talking to leaders, what do they know about either a particular investigation that is being, that they are investigating, a particular event that was alerted, and as well as also getting to know, maybe talking to relatives of the case that is identified here to get more details, and then the story surrounding how this case came about. And this is mainly, it's been very successful and have produced over 600 contacts out of the 7 cases that we have. So we have over 600, one producing more than 400, and the others producing an average of 20 over the 7 cases that we have. And then we also have, we focus on following up on the rumors. A lot of people come in because of the eagerness. People have this experience of Ebola, so they don't take COVID lightly at all. So the rumor of, okay, we're having a traveler that came in, people are alerted to be sure to notify or call 117. When you see someone whom you have not seen over the past 1 month in your community, just call 117. We will investigate where are you coming from. Because the government had quarantine and then stopped movement. The airport is shut down. The borders across the neighboring countries are closed. However, people beat the system. We have travelers who will use other means. They have their porous port of entries, people coming into the community. So there is this approach that communities are alerted to call the toll-free number. And this investigation is ongoing on a day-to-day basis. All these alerts are coming in the morning. I sit with the surveillance pillar at the national level here. We review these alerts that are coming and dispatch investigators into the various zones to investigate them and then to see what will they turn out to be. And most of the testings we have done are really negative. And some that are travelers are sent to mandatory quarantine, which are government-manned quarantine facilities within the city. And then those that are really false alert, maybe just individual that went to one district and then coming back, we just, okay, this is not what we are looking for. So there is active awareness within the communities, and then the communities triggers a lot. And then when they even see someone who is very close to someone they know has been confirmed as a case, they will call. And those are the type of alert that are coming, and it's really intense here. And then following up all of those rumors as the key approach that the country is using. And to date, we are at 7 cases. That's the experience we have here.
Thank you so much, James. You are a very eloquent speaker and have answered many of the questions that are coming in about what's happening and how to think about these different issues. So we really appreciate you being with us today. There's also a lot of experience in our various participants that have signed in. And so I do want to recognize that many of you are bringing such a rich background and history and wisdom that I hope that we can continue this One Health community of practice so that we can all keep learning from each other as we move forward on these types of things. We're going to take the next few minutes to do a little bit of question and answer. We've received a lot of very good questions and we may not get to all of them, but at least we can touch on a couple of the common themes. So I think, Millie, if you're able to use your microphone or video, if you would like to get us started with your question, that would be great.
Thank you, Trina. My question is on how we prepare families and communities to receive recovered patients. We're seeing a relatively high level of stigma, and I'm wondering what is happening. In Uganda, we haven't yet seen any patients recovering, so I don't know what actually the situation is. But in countries where this is happening, if maybe someone can share what is happening and what are the interventions that countries are putting in place to prepare communities and families to receive these individuals. Thank you.
Thanks, Millie. Dr. Masanja, do you have thoughts to share from the Tanzania perspective related to helping to sensitize families and communities as we move further along in this sort of epidemic? You're on mute, so we can't hear you yet, but it looks like you're ready to talk.
Okay, sorry.
There we are.
Yes, I said I don't, not really, but of course there's been a lot of talk on the TV, but also on the radio, especially by the minister, trying to emphasize that, you know, the people who have just recovered, they are not, one, of course, they're no longer, at least for the moment, are going to be transmitting. But of course, some cases of, you know, people wanting to see a case of COVID, how does it look like? Because there's one instance, one of our staff traveled, she was actually attending a meeting in Uganda, and then she flew back to Dar es Salaam. Internally, as an institute, we had a policy that she has at least to self-isolate for like 5 days and observe. And then she was ready to travel to Ifakara. When she got to Ifakara, she developed kind of flu and, you know, she was sneezing. So she went to the hospital, and the team at the hospital at St. Francis took over, and the team that is responsible for COVID, they isolated her, and news immediately spread around that there is someone from Ifakara Health Institute has corona. So this was, and it spread very quickly because some of the people called, you know, to find out, you know, where she has been and why we didn't take all the necessary measures. Anyway, she was they did test her. In a few days, she was released. But I think the issue of stigma needs to be addressed at a much higher level, because otherwise it will create more confusion, and yeah, that is what I can say for now.
Yeah, it is a very difficult issue. James, do you have anything to add based on your experience previously with Ebola, or when you think about what might be effective for trying to address challenges with stigma and moving forward to help patients who have recovered move back into their normal lives? You're on mute. Go ahead and unmute, James.
Yes. Yes. Today within the pillar meeting, we discussed, because we're expecting that we will release the first cases that we have. How do we get them out? How do we take them back to the various communities? And especially the first case was really all over the social media, and then getting back this person home, and they are all associated to health care workers, relatives or family members of healthcare workers. We talked through using the same Ebola approach, and though uncertainties were there when this individual is discharged, recovered, and then sent home, the possibility of getting sick again and being readmitted again. So how do we frame the message to the community, and then to receive them back? So it's the key discussion was sensitization, and the psychosocial people, the team, going on radio, letting them know, okay, this individual is a good thing, like pointing out that it's a good thing we're having people recover, and we should hail them. We should really hail their bravery and really point that out that they've been brave, and then maybe take them to the media, get some audio like interview with them. Those were some of the strategies we were discussing. We haven't had any recovery yet, but we hope to have soon, and the discussions are on the way. With Ebola, what we did was to really take them and hand them over to the community. There was this problem of contact. Ebola was a contact as well, stigma that once you touch the individual, you are exposed. So we have this strategy of hugging them in front of the family, just having interactions with them, touching them, and to make sure that these are not infectious anymore. They are human beings. They are not the virus. And then don't fear them. They have recovered. They are okay. The early stage, what we knew then about the disease. So those are the same approach we have been discussing. But there is this uncertainty on once an individual has recovered, and then the reinfection, and then also getting sick again and going home as critical, that we have to be cautious on how do we move forward with that. But those are where we discuss around that.
Thanks very much, James. So one of the other themes that's come up in the questions before and during the session relates to the One Health approach, where we think about what's happening with diseases that may affect people, but also the animals that we interact with, and potentially can spill over in both directions. So I'm wondering whether Julius or Bernard, I see, and even Dr. Eddie is on from our Gorilla Doctors programs, would you be able to share any of your experience related to surveillance in primates and humans in the protected areas of East Africa? I can be able to share my knowledge of it, but I think if we have Bernard or Julius who would like to briefly touch on the idea of how do we think about these diseases at the primate-human interface, that would be welcome from your experience.
Yeah. Yes, hello.
Hi,
Can you hear me?
Yes, go ahead.
Yeah, thank you for having me, and thank you for this opportunity. At the Gorilla human interface, of course, with this scare, there has been measures, especially in Rwanda, Uganda, and DRC, led by gorilla doctors and the corresponding government departments of wildlife, where We have engaged, particularly in Rwanda, we have again quickly sensitized the wildlife personnel about COVID-19. We are also, of course, testing respiratory samples or non-invasive samples from the mountain gorillas, mainly fecal samples, to test them for coronaviruses. And of course, this is a continuation with the PREDICT. So there are the efforts, and of course, from the human aspect, or the tourism has been stopped in Rwanda, and people are there are no more tourists going to the gorillas. Again, there has been also scaling down of park personnel that go to the park, meaning we are remaining with very vital, small percentage of the personnel that mainly focusing on health monitoring and also implementing some of the law enforcement activities like snares, looking for snares. So it's really at that aspect, and most of the other activities, of course, have been from the human aspect, have been taken over by the Ministry of Health, where even our staff members who are going to the gorillas, they had to be first tested so that they are coronavirus negative. So those are some of, in a nutshell, those are some of the activities. And of course, at country level, we are under almost total lockdown, actually complete lockdown, no moving in the provinces. Businesses are being closed down and schools are being closed down. So again, all of these efforts will help us again to see if there's no potential spill over to the gorillas or vice versa. So of course, at gorilla doctors, particularly in Rwanda, and I think this is also from the regional aspect, is we are at the forefront, especially in making sure that we teach the staff about proper tourism rules, tracking rules of the mountain, so that there is also maintenance of distance, there is provision of PPE, there is promotion of hygiene and sanitation practices at park levels, and this is, we think, and we hope this is going to be very, very full in the long run. Thank you.
Thanks so much for sharing your ideas and experience coming from the Rwanda places. So I think we should go to Dean Bazeyo and Dr. Naigaga, unless they would have any comments or additional thoughts to share on the topics that we've heard about today. Dean Bazeyo or Irene, would you like to share any thoughts?
Okay, mine is actually sort of a question to the African colleagues about integration of the private health workers. We are seeing that in Uganda, private health workers are kind of left out in the picture. So how is that playing out, especially for Sierra Leone? I see that they really have low numbers. Is the private sector involved? And how are they integrated within the response? I submit.
Thanks, Irene. So James, any very brief comments on how the private sector has been involved in Sierra Leone?
Yes, for the clinic, the private facilities.
Irene, can you speak, please? Irene?
Thank you, Dean Bazeyo. Irene has just shared a question that James is briefly sharing his thoughts on, and then we can come to you for any closing comments. Just one moment. Okay. Go ahead, James.
Yeah, the country adapted and we assigned like case investigators at private facilities and to work with the clinicians at the various facilities to prompt investigation of any suspicious cases they are suspecting. And then also the private facility management are added into the various pillars, like for case management. They are included as pillar members discussing case management matters within the surveillance pillar, which where I see it today, which I work with. We also do have private entities, non-governmental organizations, and private like the traditional healers, because we are focusing now at this point, when we don't have more cases, that could these cases be in the communities, going to traditional healers, going to seeing private people. So we have their leaders joining the pillar meetings where we discuss what needs to be done, the notification, what we require of them, and then how can they help us do our job better, especially with the team out in the field. Whereas for those who are private practitioners, like private facilities, the ECBDS, the electronic case-based surveillance system, is rolled there. They are given the tablet, the tools to be working there, and then the officers are assigned there. So basically, that's the two approach the country is using in the involvement of the private health workers. And then the use of the community health workers as contact tracers. It's critical. These are residents in the local communities. So they know themselves, they know who are there. They serve as the eyes and ears of the response team. So giving them addresses, they locate these addresses very quickly. So the issue of we don't know the address, the issue of we having this challenge is being minimized. It's not completely erased, but it's minimized. And as well as also the utilization of like social workers within the quarantine pillar to help with the quarantining processes also has helped. And most of the people that are serving as officers within the quarantine process are private, not non-health work professionals. So those are the measures the country is using here.
Thank you so much, James. So we're going to need it to wrap up our session. Dean Bazeyo, do you have any final closing comment that you would like to make, or shall we go to Professor Mazet?
I just want to thank everybody for participating, especially the presenters, and I want to thank the Tanzanian colleague who has given us the details of what is happening there. My only worry is that they are only looking at only the people who are sick. I suggest that they look at all their contacts and they bring them under quarantine. The second thing is that what I noticed is that when their patient tested negative, I think twice or 3 times, they discharged. But the recommendation is that you keep that patient at least 7 days more. At least 7 days more, not to mix with the public, because we do not know the pattern after that. Thank you very much, and everybody, thank you.
Thanks so much, Dean Bazeyo. Over to you, Professor Mazet.
Okay, wonderful. Thank you all so much. It was amazing to hear the global digital surveillance perspectives, and then from 4 countries in Africa, the different experiences that you're having so far. It's also wonderful to know that the cases are few still in your countries, and we hope that testing capabilities and physical distancing and the other measures will keep those numbers super, super low. I do want to echo my colleagues' points that that it is difficult still in these days to know when a person is contagious or shedding virus and available to infect neighbors and family members, and when they're not, because there is a lot of low morbidity or sort of mild cases as well as asymptomatic cases. And so the testing is so important, but we know around the world that's been the difficult obstacle. So I hope that in your context, in your laboratories, you can have access to better tests. And we heard about some good news and potential for that. I again thank everyone and thank the academics and USAID for supporting the university networks so that you can be great sources of information and strong voices for science in this difficult time. We're going to see a lot of rumors. We've seen them all over the world, but you're going to continue to see them. Great points brought up about stigma and how to deal with that, and that's going to vary quite drastically by social context. And then we want to understand better what is possible and what has been learned by the sheltering in place. And we're getting now great information coming in from different countries. As Adam mentioned, California's going into the 4th week. In our area, I think we're going into the 5th week, because even our area went even stronger and earlier into sheltering, and that's working, but it has its trade-offs for mental health and also economic kind of devastation for people's livelihoods and then locally, regionally, and globally. So those are some of the questions we'd like to tackle in the following echoes, as well as continuing to learn and bring the One Health approach, understanding environmental and animal issues as they develop. So thank you again, and we're looking forward to joining you really soon with our next iteration.
Excellent. Thank you.
Okay, Bruce, any last housekeeping to share? I know we're at the end of our time.
Great. Thanks, everyone, again. Wonderful session. We will be sending links to the recording. It should be available in the next day or so, along with links to all the presentations. They'll go to everyone who registered. And we just want to encourage everyone to please complete the continuing professional development survey. It's a quick survey, and it will really help us improve what we're doing and serve you better. So thanks again to all the presenters and to all the participants. Be safe.
Thanks, Echo.
Wonderful. Thank you.